Hello and welcome. I am Dr. Onyema Obuagu, and on behalf of CME Outfitters, I would like to welcome you and thank you for joining us today for the CMEO briefcase entitled Looking Ahead, Long-Term Implications of HIV Pre-Exposure Prophylaxis Treatment Decisions. Today's program is supported by an educational grant from Gilead Sciences. My name is Onyema Obuagu, and I am an Associate Professor of Medicine of HIV and Director of the Clinical Trials Program of Yale, the Yale AIDS Program in the Section of Infectious Diseases of the Yale School of Medicine in New Haven, Connecticut. Today's learning objective is to apply clinical trial data and other available evidence to decision-making for the management of patients taking PrEP. Now let's talk about the risk of certain individuals for acquiring HIV. We do know in the United States that transgender women are disproportionately affected by HIV. It is estimated that of all transgender women in the United States, 14% are living with HIV. When broken down by racial and ethnicity demographics, we see that racial and ethnic minority transgender women are highly impacted by HIV. This includes almost half of Black transgender women, as well as more than a quarter of Latinx and Hispanic women having HIV. The number is much smaller for white individuals at 7%. In spite of this very high risk of acquisition of HIV, unfortunately, the uptake of PrEP among Black and Latinx transgender women remains very low, with only about 17% of those who would benefit from the intervention being on it. Now let's take a look at some of the social ecological barriers to PrEP uptake and adherence among Black and Hispanic Latinx transgender women. We do know that the efficacy of PrEP is strongly tied to adherence, and so identifying and addressing these risk factors are really critical. Some of these barriers range from individual factors, such as concerns around cost. We do know that individuals who have mental health or substance use issues do have difficulties adhering to medications. And then rightfully, some individuals are concerned around the side effects of PrEP, as well as interactions with the hormone therapy, one of the issues we will address in the slide deck today. There are also interpersonal and community factors that impact individuals' willingness to uptake PrEP, and these include romantic partner influence, stigma, both within the community and also within healthcare settings, negative community opinions around people who use PrEP, including perceptions around them being a high risk for acquisition of HIV, and then also the critical patient-provider communication revolving around sexual risk factors, risk behaviors, and ways to mitigate the risk of acquiring HIV. And as well as structural factors, including employment, housing, insecurity, and transportation that limit an individual's ability to access healthcare. Let's now talk about our case today and meet Christine. Christine is a 25-year-old transgender woman who has been taking FTDF for PrEP for 5 years and has been consistently adherent. Lately, she has been seeing a lot of discussion on social media around PrEP and drug-drug interactions with feminizing hormone therapy that has her concerned. Let's take a look at the interaction between Christine and her healthcare professional.
Hi, Christine. Nice to see you. How are you today?
Hi, Dr. Wilkinson. I've been doing well, especially considering everything going on with COVID, but I'm fully vaxxed, so that gives me some peace of mind. It's better than not being vaxxed.
Oh, you're right about that. There are only so many things we can control, and being vaccinated is a step in the right direction.
Yeah.
Well, thanks for stopping by the health department and getting your labs drawn. So everything looks good. Have you been taking your PrEP lately?
I've been good about taking it. I set reminders for myself, which is definitely good, but it helps to talk about something that's kind of been on the back of my mind lately. It's been popping up on social media quite a bit, and it has me a little concerned.
Okay, well, let's talk about it.
Well, I've been on PrEP for 5 years now, and I'm really confident that was the right choice for me. But I'm starting to fear, because there's been a lot of noise, that it might interfere with my hormones. It's taken me a while to get where I am, and I don't really want to mess with things and take a chance that the hormones stop working.
What would be your recommendation for Christine based on her concerns about PrEP? Now let's discuss the data for PrEP and gender-affirming hormone therapy. The data we are presenting arises from a paper by Grant and others in Clinical Infectious Diseases in 2020, and this looked at sex hormone concentrations before and after FTDF doses. The study evaluated these drug concentrations among transgender men and transgender women. In both of these groups, serum estradiol concentrations as well as total testosterone concentrations were assessed before and 4 weeks after initiating FTDF. In this study, they found no significant differences in serum estradiol concentrations and total testosterone concentrations in both transgender men and transgender women. These data provide reassurance of the lack of significant interactions between PrEP and sex hormone levels. Now let's go back to our patient interaction.
I understand that, sometimes these urban legends can take on a life of their own and still pop up. But, the data does not support that there are any negative drug-drug interactions between FTDF and feminizing hormone therapy. In fact, just this past year, there was a study presented at AIDS 2020, and they looked at transgender men and transgender women, and there was no negative impact or drug-drug interactions. So actually, there's no scientific data that supports this theory that PrEP will interfere with any, transition-related goals.
Okay, awesome. That's good to hear, because there's been so many conspiracy theories out there lately. And having said that, since I've been on PrEP for about 5 years, is there anything that I should be concerned about?
Is there anything in Christine's current medical history that causes any concern? Now let's look at the implications of sex hormones on bone mass. We do know that estrogens and androgens promote bone acquisition of bone mass during puberty and help to maintain it thereafter. Similarly, declines in estrogen levels in females as well as androgen levels in males lead to loss of bone mass as individuals age. Throughout life, estrogens and estrogens influence the generation and lifespan of osteoclasts and osteocytes. We continue to learn more about the long-term impact of gender-affirming hormones on bone mineral density. And I will say that studies have been conflicting, and we do need additional studies to assess the long-term impacts of these gender-affirming hormones on bone health. Let's discuss the stages of peak bone mass or bone deposition as an individual develops and grows. We know that puberty is the time for new bone formation, and roughly about age 20 to 30 is the time that bones achieve their peak mineralization and strength. And those who develop a peak bone mass when they are young are better protected against osteoporosis and related fractures later in life. It is important to be aware of the risk factors for low bone mineral density. And low bone mineral density can manifest as bone-related conditions such as osteopenia and the more severe form of bone demineralization, which is osteoporosis. There are certain lifestyle factors that have a negative impact on bone health. These include smoking, a sedentary lifestyle, poor diet, including deficiency of vitamin D, as well as calcium, and substance use disorders such as alcohol use and methamphetamines. Eating disorders have also been associated with micronutrient and other deficiencies that negatively impact bone health. Similarly, a low basal metabolic index is also a risk factor for low bone mineral density. So now let's assess the association between PrEP use and decreases in bone mineral density. While FTDF for PrEP has been shown to be highly effective and safe, it has been associated with declines in bone mineral density. In clinical trials, there's been a documented 0.5 to 1.5% decline in bone mineral density with long-term use of the compound. These decreases tend to occur early, typically within the first 6 months to 12 months of exposure. However, there is some good news. In an opt-in sub-study of IPREX, including about 500 individuals, they explored the question whether decreases in bone mineral density were reversible after treatment discontinuation. Reassuringly, in that study, they actually found rebounds in bone mineral density in FTDF adherent participants of 1% within a 1 year to 1.5 year timeframe compared to those on placebo. Now let's discuss the Discover trial. This was a multinational, randomized, double-blind, active controlled phase 3 non-inferiority trial that compared 2 tenofovir prodrugs, TDF in combination with emtricitabine, as well as TAF in combination with emtricitabine. This involved over 5,300 participants and included cisgender men and transgender women who have sex with men. In that study, the primary outcome was incident HIV infection. Important secondary outcomes, primarily relating to safety outcomes, were assessed and reported as a percentage change from baseline. Some of those secondary outcomes would include bone mineral density measured at the hip and the spine, as well as biomarkers of proximal tubular injury, which included urine beta-2 microglobulin to creatinine ratio, retinol binding protein to creatinine ratio, and they also assessed for clinically significant elevations in the urine protein to creatinine ratio and changes in the estimated GFR by using the Cockcroft-Gault formula. Let's discuss the differences in HIV incidence between the study arms. This was assessed at weeks 48 and weeks 96. The study, again, was designed as a non-inferiority trial and found that at both time points, even though there were numerically less infections in the FTAF arm, it was non-inferior to FTDF at those 2 time points. And if we look at the incidence rate ratio between them, they fell well within the non-inferiority margin of the study. This supports similar efficacy of FTAF compared to FTDF for the prevention of HIV infection among cisgender men and transgender women who had sex with men. Now let's look at some safety outcomes, and this would include the differences in bone mineral density at week 96 between participants who received FTDF and FTAF. As we are all aware, measurements were done with DEXA scans at the spine and in the hip. The figures shown highlight the trajectories over time of spine and hip bone mineral density for study participants. In blue are those who received FTAF, and in red are those who received FTDF. Across both measurements, individuals on FTAF experienced increases in bone mineral density over time as against those on FTDF who experienced declines in bone mineral density over time. Now, while the long-term clinical significance of these derangements are unknown, it's pretty striking the effect on bone demineralization with FTDF and the absence of that finding in those in FTAF. For the transgender women in the Discover trial, there were no HIV infections. They had similarly high levels of intracellular concentrations of FTDF between those who were on transgender women on gender-affirming hormones and men who had sex with men. In that study, there was no effect of FTDF or FTAF on ethinyl estradiol exposures. Based on risks for decreases in bone mineral density, would you switch Christine from FTDF to FTAF? Now, Christine is switched to FTAF. Which of the following is recommended by the CDC for follow-up testing and monitoring for an individual prescribed PrEP? Now, it's critically important for individuals that we initiate on PrEP to engage in appropriate follow-up. Typically, patients within PrEP programs should be seen every 3 months after PrEP initiation. During these visits, it will be important to continue to screen for HIV. This would include preferentially using an antigen antibody test or an HIV viral load on a case-by-case basis as indicated. You want to make sure that you check lab tests to assess the serum creatinine and creatinine clearance, and also during each visit to provide medication adherence counseling and support, as well as behavioral risk reduction. For everyone, screening for STIs at every orifice in which sexual intercourse is engaged would be critically important. And for women of childbearing potential, checking a pregnancy test. For people who inject drugs, pointing them to resources where they can access clean needles and syringes and drug treatment programs will be essential. Every 3 months thereafter, you want to repeat HIV testing, continue to provide behavioral risk reduction and medication adherence support, and repeat screening for bacterial STIs, as well as pregnancy tests for women of childbearing potential. Every 6 months, you continue to screen for sexually transmitted infections and keep an eye on the serum creatinine trajectory. Now, we've mentioned how important it is for adherents to optimize the efficacy of PrEP. PrEP only works if it's taken correctly and consistently. There are certain barriers to adherence that we need to address among our PrEP patient populations that are critical to having them maintained on PrEP. These include addressing active substance use, ongoing discussions around side effects of PrEP and managing them. Typically, these side effects tend to occur early, the so-called startup syndrome, and resolve pretty quickly thereafter. We need to address issues around individuals' misperception of their HIV risk through education, and also address deficiencies in social determinants of health that may impact the ability to access and remain in HIV prevention services. So let's discuss some factors that could facilitate adherence to PrEP. Some of these work on the individual level. There are certain things that emerge as successful provider support strategies. And also, we cannot overemphasize the importance of support from peers and families to be able to adhere to PrEP. Certain individual efforts, including external reminders, use of pill boxes, tying medication use to daily activities, such as brushing one's teeth, and an ongoing conversation around the perceived risk of HIV infection, as well as the benefits of PrEP, would be important. And there are certain things that providers can do to support adherence with their patients. Individual counseling sessions tailored to individuals' concerns, keeping that counseling going during follow-up visits, as well as just developing a rapport with patient populations to identify what their needs are and communicating with them, establishing trust and offering consistent quality of care. We do know that having family and peer support, both for reminders and support, can be critical. There are certain long-acting PrEP that are in development that we'd like you to be aware of. One of the most advanced of these products is cabotegravir, which is a long-acting injectable that is an integrase strand transfer inhibitor that was studied as an intramuscular injection given every 8 weeks in comparison to FTDF among men who have sex with men and transgender women. This option through clinical trials has been shown to be a safe and effective alternative for HIV prevention. However, certain things need to be borne in mind. Within the clinical trials of the injectables, a high percentage, 81%, reported injection site reactions. And also, it was noted within the trials that those who acquired HIV infections, in some rare cases, integrase resistance was detected, and there were also delays in HIV infection. However, this portends well for the future of PrEP, where in the near future, there will be multiple options for PrEP for individuals at risk for acquiring HIV. So let's summarize our discussion with our SMART goals. And these are goals that are specific, measurable, attainable, relevant, and timely. That is what I hope you will take from this presentation to apply to your practice. And some of these would be that you recognize the unique challenges and barriers faced by transgender women that may impact uptake and adherence to PrEP, that you reinforce safety and efficacy of PrEP, including reassuring about the lack of interaction between gender-affirming hormones and PrEP, a concern for transgender women, and also that you're able to integrate risk factors associated with decreased bone mineral density into treatment decision-making for PrEP. Today's CMEO briefcase is part of a three-part series of case-based activities that can be found on the Infectious Diseases Hub at cmeoutfitters.com. I hope you will check out the other two activities in this series. The Infectious Diseases Hub has these activities and many other activities on HIV. CME Outfitters also has an HIV patient education hub with a number of excellent resources, videos, and whiteboard animations to share with your patients. Thank you for joining me today. Don't forget to complete the post-test and evaluation. As a reminder, this activity is also available for ABIM Maintenance of Certification credit. Stay safe, and thank you again for providing the best care for your patients.